Well, well. Hello. A cordial greeting to all of you who are watching us at Intensivist and Entrevista. Today we have as our guest Dr. Joost Wiersinga, right? The name.
Perfect.
He works at the Department of Medicine in the Division of Infectious Diseases and teach and research at the Center of Experimental Molecular Medicine, all at Amsterdam, UMC, and he participates in the clinical guidelines on pneumonia and sepsis and coordinates the ACE 2020 EU-funded European Sepsis Academy. I'm right, Doctor. Welcome.
Thanks very much, Edgar. It's a pleasure to be in your show.
Thank you, Doctor. Well, today we will talk about biomarkers for sepsis, and for those interested in furthering the knowledge on this topic, we recommend a literature search in Dr. Wiersinga's line of research, and we would like to highlight the paper Host Response Biomarkers for Sepsis in Emergency Rooms, selected for the annual update in intensive care and emergency medicine 2023, edited by Dr. Jean-Louis Valzon. Before going, Doctor, into the main topic, I would like to ask you, what guided you? What has led you to research and study these branch of critical medicine over the years?
Yeah, thanks very much, Edgar. Well, I'm intrigued by sepsis. So I think that we all know sepsis as a severe illness, as a severe syndrome. We all already treat it on a daily basis. And a lot of research is going on in the sepsis arena with the ultimate goal to improve the outcome of patients suffering from sepsis. However, when you are critical in the last couple of decades of sepsis research, no new specific sepsis treatments have been developed.
Yeah.
So I think there's so much potential to try to improve our care for sepsis, and I think that's intriguing. And I think the research field is really, fast-paced forward. A lot of novel development, a lot of novel insights. And what drives me is to see if we can better understand this sepsis syndrome, and by better understanding this syndrome, develop better management strategies that at the end of the day will really improve outcomes for patients suffering from sepsis.
Okay. Well, in that line, in that order of thoughts, when or how did it happen that the physicians in charge of critical patients realized the importance of biomarkers? I mean, using this instead maybe of just the patient's clinical condition.
Yeah, I think sepsis biomarkers have been studied for ages, right? So at least when you look at the literature, at least 250 different biomarkers for sepsis have been studied. But in real life, what we use in everyday clinical practice is not so much. Sometimes we use CRP, some clinics use procalcitonin, not much more. So I think it has been studied for a long time, but I think before you use a biomarker in everyday clinical practice, you really need to demonstrate that it will benefit patient care and show the studies with real important clinical endpoints. And for the vast majority of biomarkers, those are lacking. However, what do you think? So having said that, I think they can be great to use. So perhaps in the future, what do you think? 5 to 10 years, we will have those rapid bedside tests on the ER, and a patient comes in with suspicion of infection, and then you draw some blood, and then within a limited time frame, the doctor gets just a couple of lines. One about is it an infection? Yes or no. 2, is it what would be the pathogen? And if it's a bacterial pathogen, you would like to have the resistance pattern. So that will be the microbiology part. But then you would also like to know, all right, so what will be the severity? What will be the short-term outcome of this patient? Will it be okay? You could discharge it with antibiotics, the patient, or watch out, with this patient needs intensive treatment. And then that machinery should also be linked to real-time epidemiology data. So is there in the region you practice perhaps an outbreak of some kind of an infection? That should also be catered in, and also, of course, the comorbidities of the patient. And then you have the whole package, and then you as a physician will get this advice. Well, there's a high chance that this is the diagnosis, and I would recommend this treatment. And you could discuss that with your patient.
Well,
I think it would be beautiful.
Yeah, and for that, the next question I want to ask you is, so which one is the ideal biomarker?
So I think that when you look at an ideal biomarker, you want to have one that can diagnose sepsis, right? You want one that can predict the severity of sepsis. But you also want it that it can help you to ascertain the appropriate treatment. And it should be able to stratify patients according to their disease severity or susceptibility to a specific treatment. Diagnosis, prognosis, and treatment decision. That would be my ideal biomarker.
Okay, and in order to get to that ideal biomarker, for example, in clinical and preclinical studies, how can the challenges of biological variability of the patient's heterogeneity be addressed to identify biomarkers for sepsis?
Yeah, so I think that was kind of a wish list I made for this this ideal biomarker. So I think our immune system is just too complex to think that one biomarker can do it all. So it should be at the end of the day a combination, I guess. So now with this multi-omic approaches, genomics, transcriptomics, proteomics, metabolomics, even lipidomics, but also microbiomics, you have those large-scale platforms that will give us so much information. And so many groups around the world are now studying that will help us, I guess, to come with a combination of biomarkers.
Yes, of course.
That perhaps could help you in this sense.
Well, I mean, determining the diagnosis and prognosis of sepsis on the emergency department is vital. But right now, with all you have said, which are the main limitations of biomarkers in the diagnosis of sepsis, for example, in the emergency room?
Well, I think they're just not good enough. So there have been a lot of studies on the use of CRP, procalcitonina, the traditional biomarkers, but also newer ones like pre-sepsin, soluble TREM1, a lot of others actually. SUPAR is another one. MR Pro ADM, and of all these biomarkers, a lot of research has been before, but also meta-analysis of all those research, and they do show that they can, to a certain degree, be used for the diagnosis and prognosis of sepsis. However, it's my feeling of the literature that up to now, none of these biomarkers has yet been proven that their use on the ER in patients with suspected sepsis will really improve the outcome, the patient-related outcome. And I think that it's just not good enough.
Okay, hold that thought, because we will go into that later about the real use of the biomarkers, because you mentioned the SUPAR, for example, and during the COVID, for example, the important experience was gained with the use of the soluble urokinase plasminogen receptor, the SUPAR, and target, the treatment with EL1 in COVID patients.
That's beautiful development. So then we go to the fields in which biomarkers are used not for diagnosis or prognostication or just treatment, but it's combined, diagnostics, that you use a certain biomarker to start or even monitor a therapy. And I think the super story is beautiful. So that's this story from these studies originally performed in Greece, based with COVID, and then anti-IL-1 was given. But the patient population was enriched, as we call it, by giving this anti-IL-1 compound only to those patients with elevated super levels.
Yeah.
And then you have this more homogeneous group, and then they were able to show a benefit. But another extremely used example that is used every day is, for instance, just anti-IL-6 treatment in COVID based on CRP levels.
Yeah.
As those beautiful studies from the UK performed by the recovery cohort. Extremely easy, CRP, everybody has it. If it's really high, patient is not improving with the COVID, you can give anti-IL-6. So that's another example of a very simple biomarker used to guide your treatment, diagnostics. And I think that's an extremely important approach. And that will also help us to try to develop better treatments for our patients with sepsis. And because we have all these failed sepsis trials, that's called by the pharmaceutical industry the sepsis graveyard. They're all just negative. But sepsis is so heterogeneous. Some people even say sepsis doesn't exist. It is just, well, some even say it is this garbage can. I don't really like that word, but of all these different diseases. But when you can really more pinpoint certain subgroup of patients suffering from a subtype of sepsis, then you can really target, kind of an immune pathway that is affected in this pathway. So this personalized medicine approach in sepsis, for that one, biomarkers are essential. And then as one example, so we are now involved in the ImmunoSEP consortium led by Professor Netea from Nijmegen. That's a pan-European consortium. And that is this first personalized medicine approach in sepsis. So what we do, patients with sepsis are screened, and if they are hyperinflammatory in their response based on the biomarker, very simple, ferritin, then we dampen the immune response by blocking IL-1 with anti-IL-1, or if they are in the immunosuppressive phase of sepsis, and then HLR-DR is used as a biomarker for that, then the immune response is boosted by giving interferon. And then for that approach, biomarkers in sepsis are also vital.
Well, that's very interesting. And that you said about the diagnostic, of course, diagnostic is a must question I have to ask you, because in this big pool of biomarkers, is diagnostic, will diagnostic give a new life to those forgotten biomarkers? Like we could...
I love your question. Yeah, I think that diagnostics actually opens a whole new field in sepsis. So actually, we just discussed all those field trials, this sepsis graveyard. Actually, I think that a lot of those old drugs can be studied again. To mention some examples, so erythritol, that is anti-toll-like receptor 4, large trial in sepsis, JAMA article, nice design, it failed. But I'm sure that a subgroup of patients will benefit from it. What subgroup? Well, we have to define that. Also, anti-IL-1 has been studied years ago in sepsis, negative studies. Then new analyses were done on those old studies using, for instance, ferritin to see if there was this hyperinflammatory response, macrophage activation syndrome. And then retrospectively, these subgroups were made and that, hey, perhaps in those patients, it does work. So yes, I think that, and that's promising, that a lot of those old interventions that were not working actually can work if you better select your patients based on biomarkers.
So those forgot biomarkers becomes new emerging biomarkers. For example, in case of ferritin, I can look backwards and use it. But about those emerging biomarkers, for example, you mentioned the TREM1. With the TREM1 happens similar. I mean, there are studies that have shown excellent sensitivity and specificity for sepsis, and others that have shown its prognosis useless. Even so, but why is not TREM1 the star biomarker, for example? Is there a future ahead with this one, for example?
Yeah, so we also studied soluble TREM1, and I think there are a lot of beautiful studies that do show significantly higher and sustained levels of soluble TREM in those patients that do not survive. Also beautiful serial time point studies. So I think that soluble TREM1 has been shown to have diagnostic and prognostic value as a biomarker for sepsis in critically ill patients. However, just to be critical, I think studies that evaluate the added value of soluble TREM on meaningful patient-related outcome parameters in comparison to other biomarkers, certainly in the R, are just lacking. But so TREM1 is very interesting. So now also there's a company, right, Inotrem, that tries to target TREM1 therapeutically in patients with sepsis. And then I think you also, in such a study, you would like to enrich your population to see in which patients would most benefit from it.
And Dr. Joost, about, for example, presepsis, because it's a useful biomarker, but it's contradictory data regarding its superiority to procalcitonina and CRP, for example.
Yeah, so presepsin, that was first described as soluble CD40 subtype already almost 20 years ago. And the beauty is that serum presepsin levels start to rise already 2 hours after infection and reach their peak after approximately 3 hours, make it a potentially valuable early biomarker. So yes, perhaps that would be a benefit compared to the other ones. However, same story. I don't think that the data are powerful enough that when you use it, it will really improve patient management. I'm a little bit critical about it. So I think that the field of the potential power of this novel biomarker in sepsis for diagnosis, prognostication, and therapeutics is excellent. However, now at this moment, I don't think there's so much added value.
If for example,
we just don't know enough yet.
For example, with proadrenomegaly, there's a few studies that report. Is there studies that report improved outcome in suspected patients with useful adrenomegaly?
Yeah, it can also assist in the diagnosis of sepsis, and it can also be used as prediction of severity of disease among patients with suspected infection on the ER. However, when such an approach will really improve patient-related outcomes, mortality, length of hospital stay, quality of life, I think we need those studies. So, for instance, another potential one that holds true for a lot of these biomarkers is that they can be really useful from an antibiotic stewardship perspective. So we are all, we all are trained that sepsis is a life-threatening disease and we have to give antibiotics fast, right? Makes sense. However, there's so much over-treatment of potential sepsis cases with antibiotics where at the end of the day, it was not sepsis, and we are giving just too much antibiotics.
Yeah.
So I think that when you design studies with these biomarkers and then just as an endpoint, use the antibiotic use from the antibiotic stewardship perspective, that would be very valuable. And I think there's added value there. But I think, well, those studies have to be performed.
Of course. And now let's talk about, for example, the hypothermic sepsis, because some profiles could change the biomarkers. I mean,
hypothermic?
Yeah, hypothermic. We know from your research, your studies about levels of endothelial activation from fractal were increasing, right? I can't remember.
That's true.
The first 4 days. What about this?
Yeah, so it's well established by multiple groups, multiple cohorts, that the outcome of patients with hypothermic sepsis is worse. And indeed, there is this difference in endothelial activation. Fractalkine was a nice biomarker for this, to study this. So that's of interest. However, before that can be used in everyday clinical medicine, a lot of steps have to be taken, I guess.
Yes, and like the temperature is a factor, and the age is another one. There is important difference between pediatrics and adults biomarkers.
Yeah, you're absolutely right. It just makes our practice a lot more complicated, right? You're perfectly right. So, of course, the immune response, and as a result, the biomarkers that will be used, is really different. And when you compare hypothermic with normothermic, or sepsis with a high temperature, or in the older age or the younger age, that means that most probably those patients also need an adjusted different treatment. That also means that when you perform studies or even intervention studies, RFTs in these groups, you want to have those subgroups. However, then you immediately have this power calculation problem, right? Because you will not have enough patients in your study for those specific subsets. So for that, I think the only solution is collaboration on a national level, international level, to have enough power for those studies in specific subsets of sepsis. And I think that is the beauty of what we learned from COVID. During the COVID area, we all collaborated, right? And there enormous success. It was a study group, recovery, active, and I think that's the way forward. And I think we as sepsis researchers can and should learn a lot from the COVID-19 field.
Yes, of course. COVID was a perfect example that what we can do with resources and times and collaboration, all of these. Two more questions. I must ask this because this topic is on the table in every area of sciences. What role could artificial intelligence play in detection of the new biomarkers?
There's a lot to gain with artificial intelligence. So, as an example, where we work on is to help that machine learning helps us to see in which patients on the ER with suspected infection we should perform a blood culture. So for that subject, so in a lot of the guidelines, it is said you should perform a blood culture in any patient before you start systemic antibiotic therapy. However, we also do know that there are a lot of harm associated with performing too many blood cultures. Contamination of blood cultures could lead to increased antibiotic use, longer stay in the hospital, even poor patient outcome. So now we developed this machine learning based algorithm to better identify in which patients you should perform a blood culture, yes or no, in patients with suspected infection on the ER. So this this algorithm makes use of all the clinical parameters in your electronic healthcare system. So vital parameters, but also all the normal standard clinical chemistry. So there is leukocytes is taken into account, but also bilirubin, a lot of parameters. And by such an approach, you can really limit the number of unnecessary taken blood cultures. And now
it's like a pretest. It's like a pretest booster.
Yes,
Probability booster.
So my colleague Rabat Nanayakara from the acute medicine, he now rolls out a nationwide program to test this in an RCT and then see if it's safe to use of meaningful patient-related outcome measurements. So I think that could be beautiful, and that's just one example in this large field of the treatment of patients with suspected sepsis on the ER, where artificial intelligence can be of help. So I'm yes, it opens a lot of opportunities. I'm very optimistic about it.
Okay, I am also. Doctor, we are running out of time, but I neglect this question to the end intentionally. We know your expertise in the area of microbiota. So, could there be any relationship between microbiota alteration and biomarkers in critical ill patients?
Yeah, the microbiome.
I know it's not fair because this is like a entire talk question.
But no, yes, there are a lot of potential biomarkers in the microbiome. So just as an example, we now are thinking what we know in patients with universally all patients with sepsis treated in the hospital, their microbiome is disrupted. Why? Because of the septic response, but most of all because all the things we are doing, giving all these antibiotics, but also all the other drugs, all the comorbidities, the way we feed patients. Anyway, we do know that almost all those patients will have a disrupted microbiome, and we do know that is associated with poor clinical outcomes. But also, we think that it is important for post-sepsis recovery. So we now thought, just as an example, perhaps in patients that survive sepsis, perhaps we can have a look at the microbiome. We would like to pinpoint it on the butyrate-producing anaerobic bacteria, and they produce butyrate, short-chain fatty acids, etc. But in those patients with really disrupted microbiome, with really low levels of butyrate-producing anaerobic bacteria, perhaps we can restore the balance there, and then as an endpoint, improved recovery after sepsis, less hospital readmissions, for instance. So that's one approach which we thought would be nice to see, to test, to use that such a specific biomarker in microbiome in the setting of post-sepsis recovery. But you can do so much more with it.
Well, Dr. Wiersinga, we would like to thank you again for providing us with your valuable time and expertise. Thanks for sharing your experience. We always be delighted to have you here, and the door is always open. I think, for example, to talk about microbiota,
that's fascinating.
It has to be an interview about 2 hours, because I know you like so much this topic.
Yeah.
Well,
Edgar, it was a real pleasure. Thank you so much.
Thank you. And thank you for joining to the intensivist. Well, Doctor, goodbye.
Bye-bye.